All right, so here in this video, we're going to go over some simple exercises that we're going to use to target strength and endurance of the shoulder, specifically with external rotation. So these would be our exercises that we're going to use when we're trying to target the rotator cuff. And in this case, because we're talking about external rotation, the bias of these exercises is really going to be on the posterior rotator cuff. So this would be the infraspinatus and the teres minor. Now, these are going to be some kind of classic exercises that, I'm sure you've seen before, but just because they're simple on the surface, we still need to be very mindful of how we're actually prescribing these to patients. Because in a lot of cases, patients are going to do this in an incorrect way with poor form, or they're going to be prescribed to patients in kind of a haphazard way with little to no attention to detail or how to make sure we're getting the form the way we want it to. And when this is the case, the quality of the exercise, but also the effectiveness is really going to suffer. So this would be an example of, keeping things simple has a tremendous effect, but we also want to make sure we're doing simple well. And that means paying attention to detail. Now, the exercises that we're going to review are going to be more from a seated position, or at least a position in which we can get the arm up and supported. And the really important value here is when your arm is up supported on something, the shoulder itself can stay relaxed. So in this case, it's the chair that's holding my arm up. It's not my muscles that are holding the arm up. And that's important because if we want to target the rotator cuff, we want to keep the other muscles, specifically the deltoid around the shoulder, quiet so it's not necessarily contributing to the motion itself. Now, the other thing we're going to find is that we can do several versions or variations of this exercise from this position. And really where those variations come in is what we're using as our resistance. So for example, we can use a dumbbell or we can use a band. And both of those are good to do, but they're different. They have slightly different stresses and how we have to do them are slightly different. Now, each of those has its own pros and cons. So we're going to go over both versions and we'll talk about, what are the pros and cons of each and how do you know which exercise is best for the patient in front of you. But we're also going to show a third exercise, which is going to show how we combine a band and a dumbbell. Now, this will be a little bit of a more advanced exercise, so it's not always the starting point. But when we can get patients to this point, I do think, as I'll discuss when we talk about the exercise itself, that this is really one of the things we're trying to get patients to be able to do when it comes to shoulder rehabilitation, because it really is a very effective exercise to create strength and create a strength stimulus through an entire range of motion. So we'll go over each of those exercises, and then at the end of the video, I'll take a moment just to briefly describe some programming and progression criteria. So this would be things like how many sets and reps, how often do they do it, what are some progression criteria, meaning how do you know when the patient is able to or ready to kind of progress to the next exercise or progress in weight or so on and so forth. All right, so let's take a look at the exercises. All right, so the first version of this exercise we're going to look at is going to be performed with just a basic dumbbell. So again, what we want, as we briefly discussed in the introduction, we just want to have the arm up resting on a chair or any other type of support that we can have. Again, as discussed, we want the muscles here to be nice and loose and relaxed in our basic starting position. The other thing to maybe point in mind is that we do kind of generally want the elbow to be a little bit lower than the shoulder. We wouldn't want to be have the arm up in flexion or abduction. That's going to create some jamming of the joint itself. So we do want to make sure there's a bit of a downward slope here. Now, most chairs work pretty well for this. Just as a side note, if a patient doesn't have the appropriate chair, they can always use something with a bit of a higher back, and sometimes just sticking a blanket or a pillow or a cushion underneath works well just to kind of lift them up a little bit to create the appropriate angle. The other thing to keep in mind is we kind of want the arm forward a little bit, it may be in about a 45-degree angle or so. Again, you can adjust this as needed if it needs to be a little bit farther forward or farther back, depending on the stimulus and what the patient is feeling with the shoulder. But as a general rule, we just want it forward a little bit, even into this like scapular plane. Oftentimes, if it's back too far, this will create a little bit more of some tension and some abnormal motion through the joint, at least in the early phases. So again, we're just going to start elbow supported with a weight. And as we do this, we're just going to let this slowly go down. We want that eccentric control of the arm going forward and the shoulder going into, in this case, internal rotation. Now, there's nothing wrong with going a little bit farther if the patient has that ability. But in the beginning, what I will often say is just simply go until the forearm is about horizontal. We're going to hold this position just for a second or two, and then we're slowly going back up so that the forearm is in a little bit more of this vertical position. Again, if the patient has the mobility, there's nothing wrong with going back a little bit further, but sometimes patients just need very specific instructions so they don't get confused at home. And oftentimes this kind of vertical to horizontal position is a really helpful thing. It just gives them some targets of what they're trying to shoot for. Now, one of the really key things to keep in mind when we're talking about form here is, as we talked about in the introduction, the key is really to keep the motion isolated to the shoulder itself. And when you're going backwards, this really doesn't become much of an issue, because if you are going to get some scapular motion, the shoulder blade is going to kind of compress into the rib cage. It doesn't really have much of a compensatory ability. When you're going forward, though, it's a little bit different, because as we're going down, what often will happen is the shoulder blade will often want to create this anterior tilt. So in this case, we're getting the arm to go forward, but the motion is really coming more from a scapular motion as opposed to a glenohumeral motion. And this really needs to be corrected. Now, if you've seen some previous videos, we've talked about this concept in the past, especially when we got into or when we discussed our movement and control exercises for the shoulder. And this is simply another example of a lot of these strength exercises are simply progressions of movements we've already spent the time teaching our patients, but that also emphasizes the point where taking the time in some of the early stages can be a really effective and a big time saver as we get into these later strength and endurance phases. So again, we're just starting elbow straight up, slowly going down. We want to be slow and controlled with the motion, hold for a moment, and then slow back up. We're keeping tall, we're keeping that shoulder blade stable so it's not allowed to move forward. Now, the other version of this exercise that we can do is with performing it with a resistance band or a cable as opposed to a dumbbell. And what we're going to see here is the movement that the patient does is going to be identical, but the resistance and the load vector is going to be very different. So as we kind of do this here, I have, in this case, my band just kind of coming across. I don't think you can see it on the video, but it's just simply attached into a door frame right beside me. And from here, what I'm going to do is I'm simply going to kind of pull backwards. Again, just like we did before, I'm driving that shoulder or pulling that shoulder into external rotation. And of course, now the band is providing resistance. I can then go slowly downward, going back into internal rotation. Again, like we spoke about in the previous video, I'm being very careful to keep my shoulder and my shoulder blade tall, not allowing that scapula to tilt forward. Now, as I mentioned in the introduction of this video, these are two very good exercise options, but each has its own little pros and cons. And I think this would be a good time to talk about this. And the big difference between these exercises is where that force or strength stimulus is applied. So just as an example, if we're using our band here, because the band is pulling along the same direction of my forearm, there is really little to no stress or effort requirement in my shoulder. Now, as I get into this upward position or more externally rotated position, this is really where the band is providing a lot of resistance. So the more we go back into these externally rotated or regressive or short angle position is really where the band is going to be extremely effective. However, as we get into this lower position, really little to no stress on the shoulder. It's a very relaxed position, really not a lot of stimulus in through here. But if we go back to our dumbbell example, the force profile of the dumbbell is really the exact opposite. So as I have my arm in this externally rotated position, the weight is going through, or the force vector is going through the joint itself. There's really little to no stimulus or demand on my shoulder or my rotator cuff in this position with the dumbbell. However, as I then go forward, internally rotated into more of that stretched or progressive angle of the shoulder external rotators, this is where the bigger load demand is going to be. So you can see it's exactly opposite of that of the band. And again, that doesn't necessarily mean it's good or bad. It's just a limitation that we need to be aware of when we're prescribing these exercises. And really, which exercise is better, or at least a better starting position, is largely going to be dictated by the exam itself. And what you'll often find is when you're testing patients or testing strength of external rotation of the shoulder, what you will much more often than not find is that the weakness is going to be, or the dysfunction is going to be more prominent in one of those two positions. So if I have a patient that tests fairly strong here, but if I get them back into a little bit more of that externally rotated or regressive angle and test much weaker here, I'm going to select the band as the starting point for the majority of these patients. And the opposite can also be true. If the issue is more that they're pretty strong and tolerant here, but there's more of a deficit or a weakness here, then I might start them with the dumbbell exercise, just because we want to target the dysfunction as specifically as we can. Now, the other thing to keep in mind is that even though either of those, the band or the dumbbell, is a good starting position, there is another option that we can use in which we can combine the weight and the band. So what we would do here is we can use a dumbbell but also use a band. So in this case, oftentimes I will have them wrap the band around the dumbbell, and then we can kind of do it in this position. So you can see now in this posture with our combined motions, the band is really providing little to no tension or little to no resistance, but the weight is. So this is a loaded position for the shoulder external rotators. Then as I go to rotate backwards, as I get into this top position, now it's the dumbbell that is doing or providing little to no stimulus, and it's the band that's creating my resistance. So again, now I have a good amount of tension and stimulus in this short or regressive externally rotated angle. Then as I go forward, again, I still have resistance in this more internally rotated angle. And this is how we kind of use this as a little bit of a more advanced exercise, because it allows us to create strength stimulus and load stimulus through the entire range of the exercise. And again, this would often not be my starting point, but as we can progress through those initial exercises, the patient gains a little bit more strength and coordination and control of the motion. This is a really good point or a really good exercise that we can try to progress them to, just to be a little bit more effective in what we're trying to do with the strength and endurance component of our rehabilitation. All right, so now that we've reviewed the exercises themselves, let's just take a moment to talk about programming. And here there's really two variables that we need to consider when prescribing these to our patients. The first is going to be frequency. In other words, how often or how many days a week are they going to perform this routine or perform these exercises? And second is volume. This gets into the how many sets and how many reps question. So first off, for frequency, remember when we are building strength and endurance, the idea is we're trying to get muscles to work a little bit harder compared with our pain tolerance or with our mobility exercises. Here we're trying to get the muscles to go to fatigue, and as we're increasing workload, we also need to make sure we're programming rest. So therefore, we're going to typically do this on a 2 to 3 times a week basis. And this, of course, is very similar to general strengthening, so patients can certainly understand this. And the idea is this builds in at least a minimum of 1 day in between training sessions for recovery. Now, the other thing to keep in mind is our sets and reps. And here, what I kind of think of is that we're going to look for a certain range. And that typically is between 8 to 12, or maybe even 8 to 15 repetitions. But to keep this simple, what I'm typically going to do is prescribe 3 to 5 sets, but I'm going to say do 3 to 5 sets of 10 repetitions. But there's really nothing magic in this number of 10. The idea is we want the muscles to be fatigued at these 10 repetitions. And when doing so, in order to kind of get the load right or the weight right, if patients are close to this, but getting into that fatigue level, then I think we're hitting the mark okay. So if a patient is shooting for 10, but they get tired around 8, I'm okay with that, as long as the quality and the form stays high. Likewise, if they get to 10, but they feel like they could do a couple of more repetitions, I'm okay with them going into that 12 to 15 range in order to fatigue the muscle and fatigue the tissue around the shoulder. However, we can also use this to gauge whether the load is appropriate. So if it's a little bit too heavy a load, whether this is too much resistance in the band or too heavy a weight or a dumbbell that they're using, and they can only perform 4 or 5 repetitions, I'm going to typically use this as an indication to lower the weight and lower the resistance in order to get to that kind of 8 to 15 level. Likewise, if they're able to do more repetitions, if they get to 15, but they feel like they have to go to 17 or 18 or 20 in order to generate that fatigue, I would typically rather increase the resistance itself as opposed to simply increasing the number of repetitions in order to get that effect that I'm looking for.